This morning we are beginning with two of our featured speakers. And for many of you, you're familiar with the first because you've also taken some courses with him either here at Teachers College or at the Columbia School of Public Health. And I'm specifically speaking about Dr. Robert E. Fullilove. And so, as you may know, he's Associate Dean for Community and Minority Affairs, Professor of Clinical Sociomedical Sciences at the Melbourne School of Public Health, co-director of the Community Research Group at the New York State Psychiatric Institute, co-director of a new program, Urbanism and the Built Environment, with his wife, Dr. Mindy Fullilove, in the Department of Sociomedical Sciences. And his wife is a psychiatrist. I'm sure glad that we cleaned up that little discussion about psychiatrists can be culturally appropriate. So without further ado, and of course, what we're going to do for the second part is we're going to go directly, well, I'll just leave it at that. Okay, so timer, we're talking about 42 minutes for Dr. Robert E. Fullilove. Let's give it up for one we love ever so dearly. And there's another thing about Dr. Fullilove that makes him especially wonderful. Historically, he has been on more dissertation committees than anyone else at Teachers College, Columbia University as an adjunct. Okay, so we really want to give it up for Dr. Fullilove.
Good morning, everyone. I'm glad you could make it out on such an ugly morning. I was actually originally going to do PowerPoint, and then as soon as I got here, it dawned on me that I know so many of you that it would probably be really something of a shock to the system if I were actually to, a lot of people are nodding, so you know what I'm talking about, right? If I were to sort of try to do the division between what you see on the screen and what you're hearing me trying to say, especially since this is what I would describe as a kind of an intimate gathering. And what I'm really most interested in doing is reflecting on something that really haunted me last night when I recognized that, number one, this is the absolute end of Black History Month, 2008. That number two is a result of speaking at so many Black History Month events. I have started to really think about what it means to be someone who was born in the 1940s and who just celebrated 64 years of life, and is trying to use the experience of having been in this country for more than 60 years to deal with and understand and put in perspective the issue of health disparities, which, at least in my family, has gone through many, many iterations. Many of you know that I'm the grandson of a physician. Dr. Robert Fullilove Sr. started practicing medicine in 1896 in the state of Mississippi, and was one of the first African-American physicians, son of a slave, to be in that position in a city that almost no one has ever heard of, Yazoo City. My dad, Dr. Robert Fullilove Jr., started practicing medicine in 1934, and for 52 years before his death, he was someone who was familiar with practicing medicine in the South, having been board certified as a physician while he was in private practice in New Orleans, and having done a great deal in the North as a physician living and working in Newark, New Jersey, treating sexually transmitted diseases as a urologist. An irony, by the way, that was lost on him, the notion that his last name was full of love, and that gonorrhea basically was paying the bills and putting his sons through prep school and college. I'm married to Mindy Thompson Fullilove, as Professor Wallace indicated, who is a psychiatrist who celebrates 30 years of practicing medicine, having graduated from Columbia P&S in 1978. And I'm someone who has had like three very distinct identities in the course of what I like to consider now as a long life. I talked about Black History Month because part of what people these days are most interested in hearing me talk about is not what I do professionally. What they're really interested in is what it was like for me between 1963 and 1968 when I was very active in the Civil Rights Movement, when I was a field secretary for the Student Nonviolent Coordinating Committee, SNCC, when I had, as was the case with almost anybody who worked in the state of Mississippi or in the state of Alabama in the Civil Rights Movement, frequent contact with Dr. King, and as a result of that, find myself often in talking to audiences during Black History Month about the degree to which people have absolutely forgotten what those eras were like. When you talk to kids in high school, Black History Month consists of a day on the Civil Rights Movement where you learn that there were two people who were involved, Rosa Parks and Dr. King, and then that was it. You go from the Montgomery boycott, the Birmingham demonstrations, to modern times. So the notion that there was so much stuff in between that is lost. Then there's this identity I have as somebody who's been working in public health for the last 20 years. Someone who has looked at the evolution of the discourse on health disparities, and who finds that the attempt to sort of reconcile all of this, what it's been like to live in a family of physicians that traces its roots back to the 19th century, to have been involved in one of the most important eras of the 20th century, and then to be working in an area that continually tries to understand how you bring the historical momentum that was created in the civil rights movement into the 20th century to talk about health disparities. What's the way of reconciling all of that? And that is really basically what I've decided it would be most important to focus on in a conversation I would love to have with you today about health disparities and what we do about it. Now, I mention that also because in the many years I've been engaged in doing public health research and public health public health policy work, I've had occasion to serve on a lot of policy-making bodies. If you read the bio that is given in the program, you see that I've spent a lot of time with the Institute of Medicine and the National Academy of Sciences, both as a member of one of their boards as well as a member of 5 different IOM committees. I've also been a reviewer for IOM reports, so I understand something about what happens when the United States government, often in the person of the Congress of the United States, asks the medical and public health community to weigh in on issues that ultimately will have budgetary impact, legislative impact, and practice impact when they think about the relationship between our laws, our regulations, and the way in which we practice medicine and do the work of public health. So I've been thinking about that a lot. I've also been very clear that over the course of the last couple of years, as somebody who does a great deal of work with HIV, that we are in the midst of a quite difficult point in our understanding of HIV and what we're supposed to do about it. Those of us who started back in the 1980s, this is my 23rd year of being engaged in AIDS research, those of us who started back in that era remember when the fight against HIV was the fight to prevent it. It was a uniformly fatal disease, so the only real public health response we had was to come up with programs that would prevent people from getting infected. And it is there that I think we started what I would consider to be the most important aspects of the discourse about health disparities. From a policy standpoint, I've always worried that beginning with HIV and ending more or less with some of the things that Professor Wallace was just talking about, namely, what do we do about folk who are dealing with problems related to substance abuse? I've worried that the discourse on health disparities appears to center our actions, our activities, our research, and our policy formation on individuals. If you say that the problems with morbidity and mortality in the United States are basically the problems of people of color, then you make them the unit of analysis, you make them the unit of activity, you make them the unit of concern. That's another way of saying that in order to fix health disparities, we have to fix the people who suffer most from its consequences. Which is an interesting approach, but it overlooks the degree to which many of the health conditions that we worry most about are not necessarily under the control of the individual, nor are they likely to cede to the kinds of interventions where we try to get people to act better. It's not always clear that people live in a world where the choices that are available to them allow them to act in their best interests. Again, hearkening back to the link between drug abuse and HIV, many of us who work in this field have talked to people who know full well the consequences of using needles that have not been cleaned or engaging in unprotected sex. But we've also heard folks describe the demons that drive them to believe that the only way they're going to get through the day is to take another hit. And we've talked to people who have engaged in unprotected sex because they were hungry, or because they needed shelter, or because they needed protection. And aligning yourself with somebody who was bigger and stronger and having sex with them was one of the ways in which you got through the night. In this instance, one of the most fundamental assumptions that those of us as healthcare providers hold on to, that people should do anything in their power to assure that they remain in good health and that they prolong their lives as long as possible, we quickly begin to see that that assumption is not necessarily true for all the folk with whom we work. If you've got other priorities, where what happens 15 years from now is an abstraction, if you've got other priorities where getting through the night becomes the number one concern, the number one priority that you're living with, then a lot of the things that we do in the way of prevention that try to convince people it's in your best interest to behave differently simply aren't going to work. What we'd really want to do would be to alter the nature of the environment that limits the choices that people have so drastically, so that by changing that environment, we broaden their choices and give them an opportunity to do the kinds of things and decide the kinds of things that will prolong their lives and protect those whom they love. So what does that mean for those of us who are engaged right now in a conversation about eliminating disparities in health? Where are we supposed to begin? If the unit of analysis is not changing individual behavior, and I'm not saying that there aren't a lot of things that we need to do to make people more responsible for their health. I'm just saying that if our major focus is going to be on coming up with the most effective strategies possible, where would we look and what would we do? I have a couple of thoughts on that I hope that you'd share with me in this. One is that for the most part, when you do work in communities, one of the first things that you discover, and I'm talking specifically about the communities that have inordinately high rates of morbidity and mortality from a wide variety of sources. One of the first things that you see is that while everybody is concerned about their health, it's not necessarily their first priority, meaning it's not necessarily the thing that they drop everything right now that they're doing to work on with you to make better. They want to be healthy. They're concerned about access to health care. But if you said, okay, I need you to come to this meeting, or I need you to take part in this program, or I need you to show up at this conference, they've got other things to do. So what happens when you say, well, what are the things that you're really most interested in? What are the things that you're willing to fight for? What are the things that you're willing to organize around so that we change the conditions that contribute so enormously to the poor health of the community? And let me just be clear that this is a question that you're much more likely to hear from a community organizer than you are from somebody who does health policy research. You recall that I said that there was a time in my life when I was heavily engaged in the civil rights movement. Well, what I did in the 2.5 years that I worked in Mississippi was that I worked as a community organizer. At the age of 20, that was probably, to this day, one of the most successful periods in my life, because I really saw a direct relationship between what I did and the impact it had on the communities in which I was working. And I think I've never forgotten, never stepped very far away from the lessons that I think you learn when you're actually in a community and you're trying to get people to join with you in creating what sociologists now describe as collective efficacy. That is to say, the capacity of a group to join together, to make decisions about what they're going to do and how they're going to do it, and then act on those decisions in a way that brings about a mutually desired set of results. So what do you learn from the handbook that community organizers use in doing their work? Well, the first and most important thing is there are often two different agendas at play. There's their agenda, and then there's your agenda. Unfortunately, those of us who do health education and those of us who do public health often come in with our own agenda, which is largely informed by surveillance statistics. So we walk into a community and say, you know, y'all got a real problem with syphilis. Oh man, it's bad. It's costing y'all money. Or, I'm really concerned about your high rates of teenage pregnancy. Do you know how many young women in this town have babies before they're 16? Or we walk in worried about the degree to which folks are diabetic. Y'all fat. Y'all got problems with your blood sugar. And every time I walk into one of the local restaurants, what do I see? I see foods that are ultimately killing you. You got to stop that. Is there any wonder that when we start to have conversations that begin with, here's what's wrong with you, people immediately turn off? Not only do they turn off because there's a sense in which we're beginning with a deficit model of dealing with health disparities. That is to say, we're telling them what's wrong with them. There's also a problem because, more than anything else, that's not what they really care about. And it's not just that it's not what they really care about. Of course they're concerned. But we fail to do the one thing that in many of our communities is the most important, and forgive me, the most polite. We've forgotten to ask them, well, what do you want to do? I mean, it's a small point, but to the degree that we walk in with degrees, with articles, with grants, meaning with money, we think that, well, after all, my education, my publications, my wealth of knowledge, and my cash really give me a certain right to call the shots. Now, I'm not hating. I've done this before. I'm not saying that I'm free of this, not at all. But after 23 years of doing this, I have observed that that isn't necessarily the kind of approach that really works. Rhetorical question, but how many of you have been involved in a health intervention where the first thing you wanted to do was hold a town meeting where you would talk about the issues? You've lined up all kinds of speakers. You've advertised in the newspapers, maybe the local community newspapers. You've had public service announcements on TV and on radio. You've asked ministers or clergy in the community to announce your meeting from the pulpit. You've showed up, a lot of you know where I'm going with this. You've showed up at the door and there were 6 people there. 4 of whom were speakers and the other 2 were married to the speakers. What's wrong with this picture? We did everything we could to pass the word, and we tried as much as possible to convince people that this was really serious. That what we're about is having a conversation that has life or death consequences. And because they have life or death consequences, we're so astounded that we throw a party and nobody comes. Well, I want to suggest again that the Community Organizer's Handbook says, well, you came in basically following a textbook example of how you're supposed to do this without actually necessarily asking people, so what kind of thing would get you out on a Saturday morning or a Friday night or a weekday night to talk to your neighbors about what's going on? It's a small point, but we are so driven by the kinds of language we use in our grants to get the funding to do this that we often overlook some of the basic principles having to do with how human beings decide that they're going to group together, work together, and ultimately produce things that are beneficial for all involved. And I'm trying to suggest that maybe the first way to begin to deal with the issue of health disparities is not to talk about health at all. That we talk about the things that people care about. What happens if you ask people, so what are the things that you care about? I actually think that I could poll all of you in this room right now, and you and I would come up with probably the same set of answers, which is spooky, isn't it? Because we already know the answers, but we don't act on it. We know that people really are concerned about employment and job opportunities. Hello? We're working in communities where unemployment often exceeds 50%. We're working in communities where adults that we are concerned about have never had a legitimate job in their lives. So that they're concerned about employment is kind of a no-brainer. The second thing that they're probably going to tell you that they're really worried about is housing, especially if you're working here in New York. The average New Yorker is now paying more than 30% of his income just to keep a roof over his or her head. There are plenty of communities where that figure exceeds 50%. And let me say that this includes folk with degrees from Columbia University. All y'all who came from someplace else to be in New York City, who love the glamour and the attraction of New York, are yourselves hypnotized by this notion. And by the way, I live in Jersey, so it's easy for me to say this. Are hypnotized by the notion that you're in Mecca. You're in the land of magic. Vous êtes ici, dans la ville la plus importante du monde. You're here in the city that's the most important in the world. The only place I know that's like this is Paris, which is why I broke into French, because I hear the same thing from those folks as well. Et si vous parlez français, mes chers amis, vous savez exactement de quoi je parle. Hein? So the whole notion that people are here and doing that and somehow separate what they consider to be their own madness from those of folk that they're working with is an important thing for us to keep in mind. I'm coming back to the notion that affordable housing is, I would have to say, counts as one of the primary issues, not just facing poor communities, but every single person in the United States, except those who are so obscenely rich that it's not even worth talking about them. The whole question of affordable housing is something that has been disappearing slowly but surely over the course of the last 50 years. And we haven't really paid attention to it enough in the discourse on health disparities. And that's largely because we take it for granted. We take it for granted that if you're not doing work with the homeless, that housing is just part of the backdrop. But there's reason why I think we have to think about housing as one of those issues that people really care about, and I'll come back to that in a second. The third thing that I think is very much involved in the work that I'm doing now, and this does affect poor communities of color disproportionately, is the issue of mass incarceration. I don't know of any family, mine included, that doesn't have somewhere in its immediate extended circle somebody who's doing time in the joint. Somebody who is in prison, on parole, under the supervision of the court, or living in the shadow of having done something stupid and having done jail time in order to pay for it. I'm suggesting that that changes so much of the outlook of young men in the community in particular, that to not recognize how much people are concerned with the disappearance of our young men off the streets, that to not recognize how much that's sort of in the back of everyone's mind, is to overlook an opportunity to get communities talking to each other about what they're going to do with problems that they're all feeling in common. Why is it important for us to think about these kinds of issues? Why is it important for us to begin a conversation with other kinds of issues than those that we're funded to talk about and those that we're funded to work on? Because I don't see any other way to rally community support behind what it is we do. Here's what happens when you have the other conversation. Part of what makes anyone who's working in a community effective is the degree to which they trust what you do. There's a kind of an unexamined assumption in public health that what makes us effective is the amount of money that we have. So a lot of us get grants that involve our demonstrating our capacity to work with community-based organizations and other community institutions like churches. We send in grants with memoranda of agreement, for those of you who speak Latin, forgive me. And we demonstrate that each person is going to get a slice of whatever pie we're given. And as a result of that, we can count on them for their support. Okay, well, this is true, but there's something sort of artificial about it, because what's driving the conversation isn't a concern for the problem that we're being funded to take care of. What's driving the conversation is simple economic need. In communities that have no resources, the golden rule applies, right? You remember the golden rule. He who has the gold calls the rules. Well, that's how we're operating. So why are we surprised when other people who aren't getting a slice of the pie don't see the problems that are so pressing for us with the same point of view, with the same concern, with the same passion? Now, I'm suggesting that it is for that reason that we have to sort of reconfigure our notions about what it means to work in the community by thinking about issues of trust. What builds relationships that allow people to go the extra mile to work on problems that we all see confronting the community? Well, number one, it's the notion that you're not there because you have money. You're there because you're someone who can be trusted. And what does trust mean in our field? That I'm not going to conduct a study, collect a bunch of data, and then disappear once the grant is over. That I'm not going to write an article that describes all the evils that exist in the community. And as a result of having this article published and widely cited, stigmatize the folk who participated in the study. That I'm not going to promise folk that as a result of doing this kind of research, things are going to get better because of what I'm going to learn. When, after 50 years of public health research, that's basically not been the case. Show me a community where some piece of research has dramatically improved the quality of life of the folks that we work with. There are examples. There are examples. Don't let me for 1 minute suggest that we aren't effective in what we do. But I'm saying that the number of times that has not happened far outweighs the number of times that it has. And as a consequence, why should we be surprised that folks don't always trust us? So how do you build trust? Well, number one, you come in and you spend enough time in a community so that people actually get to know you. Now, what does that mean, that they actually get to know you? It doesn't mean that they see you all the time at meetings, but they see you in other kinds of settings where you're doing something for them, for which you're not asking payment, and for which you're not demanding there be some kind of quid pro quo, some kind of return. That if somebody says, I need to have you come speak to my young people, that you do that, even though it may not be something that's funded by the grant. That the whole notion about building trust is people will work with folk that they know. But after 50 years of working with folk that they don't know, who've ripped them off, it becomes that much harder for us to convince the people that we want to work with that we somehow are different. Well, the only way you demonstrate that you're different is by doing things differently. Don't come in with the same script, doing the same things, expecting different results. The Community Organizer's Handbook always says people have to see it. They have to see it in the small places, they have to see it in the large places, and they have to know that they can count on you. The only way we're going to really begin this dialogue, I'm suggesting, is by making sure that people know us for other things than the activities for which we're funded. Second point that I think is really associated with that is the whole notion that people also need to know that there is, in fact, something in it for them. And I'm not talking here about money, I'm talking about the degree to which we talk about ways in which we are able to demonstrate to people that small actions can produce large results. One of the most effective health community organizing strategies I ever saw had to do with college kids from a community that I can't name because I think this is actually a publication that's under press, who worked with high school kids to help them get into college. Turns out that in the local high schools, the kind of career counseling and college counseling that many of us in this room benefited from simply does not exist. The young public health students who were involved in this project came from all over the country, had gone to all kinds of different colleges, were willing to write letters on behalf of students, introducing young people in this group that they were working with to the schools that they were interested in attending, organized college visits, some of which were paid for by the college, and earned an enormous amount of goodwill simply because a lot of the kids who went on these trips left the community and traveled to another state for the first time in their lives. It seemed like such a small thing. It wasn't paid for by the grant. But the amount of goodwill that it earned had a lot to do with, at the point they wanted to do the health fair, having large numbers of people show up. Here's a final point that I think we all have to confront. And this goes back to an issue I wanted to talk about earlier, that I raised earlier. A very sage public health scientist whose work I trust and admire greatly Michael Marmot, has often pointed out that our very American approach, I think that's the word to use, towards problems is to fail to understand how much all of us are in this together. He used to say that if you really looked at health, you'll see that it exists on a continuum. And in a complex, interactive society like ours, where we're just one system, we fail to understand the degree to which what happens to people at the bottom, at some levels, affects people at the top. He says one of the most foolish strategies that one could implement would be one in which we focus all of our resources on folks at the bottom and fail to understand the degree to which we're all sort of in this together, that our problems are all interconnected. Housing is, I think, the best example of this. The subprime crisis first hit poor communities of color hardest because those were the folk who were in communities where almost everybody had a very low credit rating, but everybody wanted to participate in the American dream of owning a house. So they got loans for houses that they couldn't possibly afford. And they got sort of suckered into something that made a lot of other people money and created a situation that for many in relatively poor working class communities has now reached crisis proportions. But to think about Marmot's point, aren't we clear that now that crisis has now become worldwide? It doesn't just affect our communities, it affects everybody. It affects credit markets. It affects more than just housing. The confidence that people have in the stock market, going up to and including hedge funds, has been severely shaken. So we're really looking at a worldwide meltdown that first made its appearance with us, but now affects everybody. Sort of proof of the degree to which we're all in this together. We are all part of a larger system that is very tightly interconnected and not necessarily amenable to the kinds of interventions that only work with a part of the problem and not with all of the problem. Now here's where I think this stuff gets really critical. All of us are in a situation where we expect, I'm talking particularly to folk who do public health, that the financing for the work we do will come from the public sector. Well, what does it feel like if you're in Ohio or in any other state in the Rust Belt where the large rate of default on housing loans is so bad, the rates of foreclosures are so high, that governments no longer have the tax income necessary to pay for the services that are necessary? How many cities are at the point of bankruptcy and as a result really basically are unable to pay the high price for the public health interventions that we know are necessary? I started this talk by saying that probably the biggest weakness we all share is our dependence on soft money. If there's no cash out there to do our work, that work doesn't get done. Does it? Nobody does this stuff for free. Here's a point that I often like to make in a Black history talk in which I describe the Civil Rights Movement. The Civil Rights Movement was not funded by federal grants. Small point, but it's rather important. The revolution will not be funded. It just won't. What a lot of us are doing right now is trying to perfect our ability to get an edge in the competition for an ever-dwindling pot of money, right? What's really draining the lifeblood of this country is this war. $3 trillion in debt. The dollar is sinking faster than the Titanic. Our money is not buying what it used to, which means that healthcare costs are going to continue to rise. We're printing money in order to do that tax bailout thing, but that's all we're doing. We're printing money. The actual value of that money hasn't changed any. And with those of you who drove here and had to fill up your tank before you got here, you're probably going to be doing what? Snickers for lunch as opposed to going to one of the restaurants down there? Well, that's happening to the entire country. If we are thinking of the creation of a health disparities agenda that will be funded with state, municipal, or federal funds, we have to face the fact that we are in for a long, dark night where that funding is not going to be available. Some of us will get it, but the problem with some of us getting it is really literally all the others who don't. What happens to the problems that we describe in our grants and contracts? What happens to the issues that we're asking our colleagues to address? They're not going to go away just because we don't get the money. And here's what I've seen in HIV. As it has felt the pinch of a switch from prevention to medical care, that people leave and they go do other things. I can't tell you how many of my colleagues who used to do, I'm talking about black male professors in institutions that do all kinds of health research. I'm talking the ones who used to be involved in HIV/AIDS who are now doing diabetes, obesity, and cardiovascular disease, because that's where the cash is. I'm not hating on them. Is everybody clear about that? This is being televised. I'm not hating. I'm just pointing out that, you got a choice. You can do God's work. Those are things that kill our folk in greater numbers than HIV. But to the degree that we're all basically being buffeted by market forces, that we continue to have these conversations as if the money will always be there, as if the resources will always be present. And what we need to do is refine our research agendas so that we come up with better ways of developing interventions that are going to make a difference, is basically to indulge in a fantasy. It ain't going to happen that way. A lot of us are going to have to go to ground. We're going to have to go to the communities. We're going to have to be there. And the work that we're going to do is not necessarily going to be funded, but I guarantee it's going to be God's work. Our communities have gotten disorganized. What's changed between the civil rights movement and now? Fundamentally, one thing. We no longer see ourselves as members of a community who are working together as a collective. Now, don't get me wrong. I'm not talking about those as being the good old days. They were not. There was nothing good about them. They were just different. And the way they were different is I could count on my neighbor to show up at church with me to talk about something that was affecting both of us. Right now, I go into a lot of communities and what I see is people who want to get out, who do not see themselves at all making common cause with their neighbors, who see that in the competition for dwindling resources, their neighbors aren't so much their colleagues, they're their competitors. And may I say that this also goes true for all the organizations that are working in this area of health disparities. We're not collaborators, we're competitors. That in that kind of world, the classic divide and conquer strategy has worked. As long as we continue the obsessive chase after the ever-dwindling grant dollar, the problem with health disparities will remain with us, and if anything, it will get worse. The modest proposal, which I admit is somewhat revolutionary, is that some of us are going to have a day job where we pay the bills, and a night job in which we do the work that brought us together at this conference in the first place. It isn't going to be funded. But history proves that when people are determined, when they have the will, and when they have the capacity to be trusted, the people will follow. The only way we're going to get rid of health disparities is to have communities decide that this is their fight. We're not there yet. But Lord willing, and with your help, someday we will be. Thank you.
Okay, we have 3 minutes worth of questions.
3?
Yes. Any questions for Dr. Fullilove? Well, what I'd like to ask, first of all, I want to thank you for that wonderful talk. And what you missed yesterday was that we put out a conference call for a 21st century global civil rights movement for health. And we actually had people put out that call 3 times. I am calling for. And so your talk was perfect insofar as you've given us a lot of practical advice about how we begin to make that movement happen. So, since we have 1 minute and 30 seconds, would you just like to make a very pointed comment to, for example, graduate students who are being trained to do their dissertations and to do research, Freudenberg suggested and has actually developed an advocacy course. But is there something specific that you just might underline just one more time that the people in this room who are graduate students and professionals might do to really make such a movement? I think you answered it, but if you could just underline it.
What would I do and what would I say? I think there are large numbers of folk who, in addition to what they do as students and as junior faculty, I think a lot of what they do involves things like mentoring. That is to say, they do a lot of volunteer activity that is not paid for. It's really out of a variety of things. Sometimes they're simply giving back. I think people see that as what they do for themselves, and everything else is what they do to pay the bills. I would like to see that script flipped ever so slightly. I'm not saying that you should give up all you have and go to serve the poor. That makes no sense. But I am suggesting that anybody who's in this institution is already a workaholic. You already are accustomed to working 80, 90-hour weeks. The issue is, if you're going to continue to work at that pace, can we work in a way in which we do what we have to do to keep the job, but are more efficient in our use with the other time that we make available to work with the people that we love and that we know aren't touched by the things that we're paid to do? How do you do that? Many of you are members of faith communities. They continue to be, as they were in the civil rights movement, the absolute bedrock of what we do to organize our communities, because in many places they're the only institutions that are left standing. That what brings people to church on Sunday morning is often the same kind of spirit that I try to suggest is present when communities organize and want to do something concrete about the conditions that surround them. Organizers do best working in the places that they know, working with the people that they know. Being intelligent about how you organize your time so that you don't wind up with congestive heart failure, as I did 5 years ago, so that you're actually on the planet long enough to do the good that drove you to do this work in the first place, is probably something that is doable. I think what we lack is a certain amount of faith. How many of you in the audience would describe yourself as ever so slightly cynical about the present and the future? Can I see a show of hands? Yeah, well, that may be our biggest enemy. The most eloquent disclaimers and the most eloquent critiques of the talks I give are from folk who know so much that they can counter every positive point I make with 5 or 6 negative ones. I agree. My argument, my approach, my démarche, as the French would say, has lots of holes in it. But if you look at the life of Dr. King, what do you see? You see a guy who did it anyway. And that's what I'm suggesting we have to do. We have to do it anyway. Yes. Thank you.
The preceding program was brought to you by Teachers College, Columbia University. Please visit us online at itunes.tc.columbia.edu.